Robin Lee of Bay Area Foot and Ankle Associates, and today I'm going to talk about nail and foot fungus. First, some background. I graduated from podiatry school in 1998 and finished my residency in 2000, and I'm also a board-certified wound specialist physician. So nail fungus. Nail fungus affects diabetics and non-diabetics approximately equally. The nail fungus usually starts off as a mild yellow discoloration and thickening of the nail, as well as loosening of the nail. So these are pictures as far as a mild, kind of a mild, moderate, and a severe case of the nail fungus going from left to right. 90% of the time, the fungus that causes nail fungus is the same fungus that causes athlete's foot fungus. So there is a hygiene component to this. As far as treatment for nail fungus, most people are aware of topical treatments, meaning things you put on the nail. The cure rate varies for these types of treatments from 0% to up to 50% in some studies, which when you look at it closer have exclusion criteria. Typically, these studies with the higher cure rates exclude nails that have more than 50% nail involvement. And for topical treatments that do involve nails with a more severe infection, the cure rate is much closer to 0. Some common topical treatments include tea tree oil, Vicks Vapor Rub. There are also various nail drops and solutions. A common one is called Fungi-Nail, and a heavily marketed one is called Jublia. There's also athlete's foot creams that I do prescribe for some of my patients because it's just more convenient to use. Over-the-counter products include Lamisil AT, Lotrimin, and prescriptions strength creams include ketoconazole and cyclopyrox. I do tell my patients that the cure rate is very low with topical treatments, and the treatment is still of value as far as keeping the fungus from getting worse and keeping it from spreading to other toes or other people. The medical gold standard treatment for treatment of nail fungus is still the quote-unquote pills you take. The most common one that's prescribed these days because of its safety profile is Lamisil, which is the brand name, or the generic terbinafine. Essentially, you take 1 pill a day for 90 days, and then you stop, and then you wait for your nails to grow out cleaner. This medication has about a 70 to 80% resolution rate at about 9 to 12 months. That's the time period it takes to grow out a nail from the base of the nail to the tip. This medication still requires a pre-screening blood test of your liver function. I've been prescribing this for over 20 years. Most, meaning 90% of my patients, do well with this medication. I do have 10% that don't, and they usually have a rash, an allergic reaction of some sort, diarrhea. Some patients report increasing headaches, and I had 2 patients in my years in practice that lost their sense of taste while taking the medication. Their sense of taste did return after they stopped. It should be noted that this medication does not, quote-unquote, vaccinate you against a future nail fungus infection, in the sense that I have patients who took the medication, cleared up their nail fungus, and then a year later reinfected themselves with the nail fungus and then had to restart the medication over again. In the past 10 years, there has also been new technology to treat nail fungus, specifically laser treatment. There are 2 types of lasers. One is a thermal laser, which uses focused heating of the nail and nail bed to eradicate the fungus. And there's a non-thermal laser, which uses a specific wavelength of light that is supposed to target the fungus and be less harmful for the surrounding soft tissue. So on the slide on the left side is a thermal laser, which it requires a practitioner to use and control so you don't cause thermal damage to the surrounding tissue. In the middle here is a non-thermal laser used to treat nail fungus. Essentially, the patient sticks their foot in this device and the light kind of scans back and forth to treat the fungus. And then in the past year, there has been a home device that you can actually get on Amazon.com. It's only been out for a year, so whether it really works or not is still up to debate. So how effective is laser treatment? The effectiveness is about 50% as it relates to clearance of a deformed toenail. Depends on how thick or thin the nail is. The thicker the nail, the lower the clearance rate. If you talk to manufacturers of the lasers, they'll quote a 90% response rate, which does not necessarily mean that you get a normal nail 90% of the time. The lasers do require repeat zaps every 2 to 4 months for the office-based units. I looked at the instructions for the home device, and that actually requires daily use for about 7 or 10 minutes a day. It is also recommended that the patient use some sort of adjunctive treatment, either a topical or oral antifungal, to improve the outcome. Laser treatment is not covered by insurances, and originally the manufacturers for the office-based lasers recommended charging patients $100 per toe and recommending that the patient get all 10 toes zapped on the initial treatment and then have follow-up zaps at a reduced rate. Fungus is not the only cause of thick or discolored toenails. Sometimes the nail can be thickened from prior injury or trauma to the nail, such as when you stub your toe, you bruise the nail falls off, and then it grows back abnormal. Sometimes it can be caused by microtrauma, meaning you're wearing tight shoes, and then most commonly the fifth toenail becomes kind of thick and rock-like. Other skin structure diseases can cause nails, like psoriasis, and here's an example of psoriatic toenails, or lichen planus, which causes kind of this splintering of the toenails. Fungus can be ruled in or ruled out with a simple nail plate culture or a nail plate biopsy, essentially a nail clipping sent to the lab to confirm the cause of. Other reasons why the nail is thick or discolored requires really a nail unit biopsy, meaning we take part of the nail plate as well as the underlying nail bed and send that to the lab for biopsy. Athlete's foot fungus. This affects diabetics and non-diabetics equally. There's three main types. There's a dry, scaly type with skin that has a yellow tint to it that's present on the soles of the feet. Sometimes we call this a moccasin distribution, meaning it affects the sole of the feet as well as the edges of the feet. There's the second type, which we call interdigital, meaning in between the toes, and it's manifests itself with a moist skin, peeling skin, and because the skin is moistened, the skin appears white. And the third type, a little bit less common in adults, more common in children, is the classic type that presents with water blisters or small blisters in the arch of the foot. In general, athlete's foot fungus isn't quote-unquote dangerous. However, I have seen cases of the interdigital fungus, meaning the fungus in between the toes, which left untreated can cause further breakdown of the skin, resulting in a wound and ulcer formation, and then bacterial infection of the wound because that area of the foot tends to become contaminated and is hard to clean. And in some instances has led to amputations of the patient's adjacent toes. As far as treatment for athlete's foot fungus, topical treatments are fairly effective. There are non-prescription topicals out there, Lotrimin or clotrimazole, Tinactin, and Lamisil cream. There are prescription topicals if the non-prescription ones don't work. I like to prescribe cyclopyrox and ketoconazole cream. The main difference between the non-prescription and the prescription topicals are that the prescription topicals tend to be what we call fungistatic and fungicidal, whereas the non-prescription creams tend to be just fungistatic, meaning they just keep the fungus from reproducing, and through the course of normal hygiene, you essentially wash off these sterile fungus. It should be noted that for treatment of the fungus on the bottom of the feet, the creams do work pretty well. However, for treatment of fungus in between the toes, it's recommended that you get a different formula of medication, either in a powder, solution, or a gel. The creams tend to moisturize the skin in between the toes a little too much, and in that way can be counterproductive. For really resistant foot fungus, you can also take the pills that are used to treat nail fungus, in this case Lamisil or terbinafine. For the treatment of foot or skin fungus, you don't have to take it for 90 days. Usually about 2 weeks is sufficient. I hope this information was helpful, and thank you for your time and attention.